Non-steroidal anti-inflammatory drugs, NSAIDs. Introduction. The NSAIDs are a group of chemically dissimilar agents that differ in their antipyretic, analgesic, and anti-inflammatory activities. They act primarily by inhibiting the cyclooxygenase enzymes that catalyze the first step in prostanoid biosynthesis. This leads to decreased prostaglandin synthesis with both beneficial and unwanted effects. The FDA has required that the labeling of the traditional NSAIDs and celecoxib be updated to include the following. 1. A warning of the potential risks of serious cardiovascular thrombotic events, myocardial infarction, and stroke, which can be fatal, as well as a warning that these risks may increase with duration of use and that patients with cardiovascular disease or risk factors may be at greater risk. 2. A warning that use is contraindicated for the treatment of perioperative pain in the setting of coronary artery bypass graft surgery. And 3. A notice that there is increased risk of serious GI adverse events, including bleeding, ulceration, and perforation of the stomach or intestines, which can be fatal. These events can occur at any time during use and without warning symptoms. Elderly patients are at greater risk for serious GI events. Aspirin has proven to be beneficial in patients for the primary and secondary prevention of cardiovascular events and is most commonly used for this purpose rather than for pain control. Non-steroidal anti-inflammatory drug NSAIDs classification. 1. Acetic acid, indomethacin, Sulindac, etodolac, ketorolac, nabumedone. 2. Carboxylic acid, aspirin, sodium salicylate, diflunisal. 3. Propionic acid, ibuprofen, phenoprofen, flurbiprofen, ketoprofen, naproxen. 4. Enolic acids, piroxicam, meloxicam, phenylbutazone. 5. Phenylacetic acid, diclofenac, aceclofenac, lumricoxib. 6. Phenamic acid, meclofenamate. 7. Others, paracetamol, tolmedin, celecoxib. Pharmacokinetics. Although there are many differences in the kinetics of NSAIDs, they have some general properties in common. All but one of the NSAIDs are weak organic acids as given. The exception, nabumedone, is a ketone prodrug that is metabolized to the acidic active drug. Most of these drugs are well absorbed and food does not substantially change their bioavailability. Most of the NSAIDs are highly metabolized, some by phase I followed by phase II mechanisms and others by direct glucuronidation, phase II, alone. NSAID metabolism proceeds, in large part, by way of the CYP3A or CYP2C families of P450 enzymes in the liver. While renal excretion is the most important route for final elimination, nearly all undergo varying degrees of biliary excretion and reabsorption enterohepatic circulation. In fact, the degree of lower gastrointestinal GI tract irritation correlates with the amount of enterohepatic circulation. Most of the NSAIDs are highly protein-bound, 98% usually to albumin. Most of the NSAIDs, e.g. ibuprofen, ketoprofen, are racemic mixtures, while one, naproxen, is provided as a single enantiomer and a few have no chiral center, e.g. diclofenac. All NSAIDs can be found in synovial fluid after repeated dosing. Pharmacodynamics. NSAID anti-inflammatory activity is mediated chiefly through inhibition of prostaglandin biosynthesis. Various NSAIDs have additional possible mechanisms of action, including inhibition of chemotaxis, downregulation of IL-1 production, decreased production of free radicals and superoxide, and interference with calcium-mediated intracellular events. Aspirin irreversibly acetylates and blocks platelet COX, while the non-COX selective NSAIDs are reversible inhibitors. Selectivity for COX-1 versus COX-2 is variable and incomplete for the older NSAIDs, but selective COX-2 inhibitors have been synthesized. The selective COX-2 inhibitors do not affect platelet function at their usual doses. The efficacies are equals that of the older NSAIDs, while GI safety may be improved. On the other hand, increase the incidence of edema, HTN, and possibly myocardial infarction. Celecoxib and the less selective meloxicam were the only COX-2 inhibitors marketed in the USA. Celecoxib has AU.S FDA black box warning concerning cardiovascular risks. It has been recommended that all NSAID product labels be revised to mention cardiovascular risks. The warning that NSAIDs can cause heart attacks or strokes. NSAID use was associated with increased risk of serious bleeding and cardiovascular events after myocardial infarction. The risk is higher among users of celecoxib and diclofenac and lower among users of ibuprofen and naproxen. The NSAIDs SC, the sensitivity of vessels to bradykinin and histamine, affect lymphokine production from T lymphocytes and reverse the vasodilation of inflammation. All newer NSAIDs are analgesic, anti-inflammatory, and antipyretic, and all, except the COX-2 selective agents and the non-acetylated salicylates, inhibit platelet aggregation. NSAIDs are all gastric irritants, GI ulcers, and bleeds, although as a group the newer agents tend to cause less GI irritation than aspirin. Nephrotoxicity reported for all NSAIDs is due, in part, to interference with the autoregulation of renal blood flow, which is modulated by prostaglandins. Hepatotoxicity also can occur with any NSAID. Several NSAIDs, including aspirin, reduce the incidence of colon cancer when taken chronically. A 50% reduction in relative risk for this neoplasm when the drugs are taken for 5 years or longer. The mechanism for this protective effect is unclear. Not all NSAIDs are approved by the FDA for the whole range of rheumatic diseases. Most are probably effective in RA, seronegative spondyloarthropathies, SPA, e.g., PSA, and arthritis associated with inflammatory bowel disease. OA, localized musculoskeletal syndromes, e.g., sprains and strains, low back pain, and gout, except tolmetin, which appears to be ineffective in gout. Adverse effects. Adverse effects are generally quite similar for all of the NSAIDs. 1. Central nervous system, headaches, tinnitus, dizziness, and rarely, aseptic meningitis. 2. Cardiovascular, fluid retention, hypertension, edema, and rarely, myocardial infarction and congestive heart failure, CHF. 3. Gastrointestinal, abdominal pain, dyspepsia, nausea, vomiting, and rarely, ulcers or bleeding. 4. Hematologic, rare thrombocytopenia, neutropenia, or even aplastic anemia. 5. Hepatic, abnormal liver function test results and rare liver failure. 6. Pulmonary, asthma. 7. Skin, rashes, all types pruritus. 8. Renal insufficiency, renal failure, hyperkalemia, and proteinuria. Aspirin. Aspirin's long use and availability without prescription diminishes its glamour compared with that of the newer NSAIDs. Aspirin is now rarely used as an anti-inflammatory medication and will be reviewed only in terms of its antiplatelet effects, i.e., doses of 81 to 325 milligrams once daily. Mechanisms of action. Irreversibly inhibits platelet COX so that aspirin's antiplatelet effect lasts 8 to 10 days, the life of the platelet. In other tissues, synthesis of new COX replaces the inactivated enzyme so that ordinary doses have a duration of action of 6 to 12 hours. Pharmacokinetics. Salicylic acid is a simple organic acid with a pKa of 3.0. Aspirin, acetylsalicylic acid, ASA, has a pKa of 3.5. Aspirin is absorbed as such and is rapidly hydrolyzed, serum half-life 15 minutes, to acetic acid and salicylate by esterases in tissue and blood. Salicylate is non-linearly bound to albumin. Alkalinization of the urine increases the rate of excretion of free salicylate and its water-soluble conjugates. Clinical uses. Decreases the incidence of transient ischemic attacks, unstable angina, coronary artery thrombosis with myocardial infarction, and thrombosis after coronary artery bypass grafting. Preventing preterm preeclampsia, history of preeclampsia. A lower incidence of colon cancer possibly related to its COX-inhibiting effects, long-term use of aspirin at low dosage. Adverse effects. In addition to the common side effects listed above, main adverse effects at antithrombotic doses are gastric upset intolerance and gastric and duodenal ulcers, hepatotoxicity, asthma, rashes, GI bleeding, and renal toxicity rarely if ever occur at antithrombotic doses. Contraindications. It's used by patients with hemophilia, antiplatelet action of aspirin. Although previously not recommended during pregnancy, aspirin may be valuable in treating preeclampsia. Long-term low-dose aspirin usage in patients with type 2 diabetes increases risk for GI bleeding. Non-acetylated salicylates. These drugs include magnesium choline salicylate, sodium salicylate, and salicyl salicylate. All are effective anti-inflammatory drugs, and they do not inhibit platelet aggregation. They may be preferable when COX inhibition is undesirable, such as in patients with asthma, those with bleeding tendencies, and, even under close supervision, those with renal dysfunction. COX-2 selective inhibitors. COX-2 selective inhibitors, or COXIBs, to inhibit prostaglandin synthesis by the COX-2 isozyme induced at sites of inflammation without affecting the action of the constitutively active housekeeping COX-1 isozyme found in the GI tract, kidneys, and platelets. COX-2 inhibitors at usual doses have no impact on platelet aggregation, which is mediated by thromboxane produced by the COX-1 isozyme. In contrast, they do inhibit COX-2-mediated prostacyclin synthesis in the vascular endothelium. As a result, COX-2 inhibitors do not offer the cardioprotective effects of traditional non-selective NSAIDs. Recommended doses of COX-2 inhibitors cause renal toxicities similar to those associated with traditional NSAIDs. A higher incidence of cardiovascular thrombotic events associated with COX-2 inhibitors such as rofecoxib and valdecoxib, resulting in their withdrawal from the market. Celecoxib, a benzoylsulfonamide. It is a selective COX-2 inhibitor, about 10 to 20 times more selective for COX-2 than for COX-1. Probably because it is a sulfonamide, celecoxib may cause rashes. Indications and dosage. It is indicated for the treatment of osteoarthritis OA, rheumatoid arthritis RA, juvenile idiopathic arthritis JRA, and ankylosing spondylitis AS. The usual dosage is 100 to 200 milligrams BID. At 400 milligrams per day has also shown efficacy as an adjunctive therapy for improving schizophrenic symptoms, most likely due to suspected neuroinflammation in the disorder. Adverse effects: fewer endoscopic ulcers than most other NSAIDs and non-inferior to naproxen and ibuprofen for most toxicities. It may have a minor effect on platelet aggregation. It interacts occasionally with warfarin and also increases plasma concentrations of both lithium and fluconazole, as would be expected of a drug metabolized by CYP2C9. Meloxicam. It is an enolcarboxamide related to piroxicam. It is a relatively selective COX-2 inhibitor, particularly at 7.5 milligrams per day. Similarly, while meloxicam inhibits synthesis of thromboxane A2, even at subtherapeutic doses, its blockade of thromboxane A2 does not reach levels that result in decreased in vivo platelet function. Indications and dosage. The drug is indicated in OA, RA, and JRA patients. Dosage is 7.5 to 15 mg/d. Adverse effects: fewer clinical GI symptoms and complications than piroxicam, diclofenac, and naproxen. Other adverse effects are listed above. Totolac. It is a racemic acetic acid derivative, relatively COX-2 selective. Indications and dosage. Etodolac is indicated for the treatment of OA, RA, and JRA. The recommended dosage is 300 mg BID, TID, or 500 mg BID initially, then 600 mg per day. Adverse effects: fewer clinical GI symptoms than non-selective NSAIDs. An increased incidence of acute pancreatitis. Has the same spectrum of adverse events as other NSAIDs, see above. Non-selective COX inhibitors. Diclofenac. It is a phenylacetic acid derivative. It is a relatively non-selective COX inhibitor. Co-administration of voriconazole may increase the toxicity of diclofenac, as voriconazole is a CYP2C9 inhibitor. Indications and dosage. It is indicated for OA, RA, and as off-label use has included biliary colic, corneal abrasions, gout, migraine, and post-episiotomy pain. It is available as sodium, potassium, and epolamine salts, as well as combined in preparations with misoprostol and omeprazole, both of which decrease GI injury. Other preparations include a 0.1% ophthalmic solution, a 1% topical gel, a 3% topical gel, and a rectal suppository form. The 1% gel is available over the counter and is indicated for OA pain and muscular pain, given as 2G applied locally every 4 to 6 hours. It is also available as an oral mouthwash and for intramuscular administration. Adverse effects. GI ulceration may occur less frequently than with some other NSAIDs. Elevation of serum aminotransferases occurs more commonly with this drug than with other NSAIDs. Adverse effects are the common toxicities listed above. Diflunisal. Diflunisal is a difluorophenyl derivative of salicylic acid. It is a non-selective COX inhibitor. It is rarely used today. Pharmacokinetics, like salicylic acid, diflunisal is subject to capacity-limited metabolism. Although diflunisal is derived from salicylic acid, it is not metabolized to salicylic acid or salicylate and retains the fluorine atoms, resulting in its longer half-life. It undergoes enterohepatic recycling. Indications and dosage. It is indicated for OA, RA, and pain at the usual dosage of 500 mg BID. Adverse effects. At 1000 mg BID inhibits platelet aggregation and may cause fecal blood loss but has no effect on bleeding time. Its antiplatelet effect is also reversible and minimal in comparison to those induced by aspirin and piroxicam. Common adverse effects are listed above. Totolac. Etodolac is a racemic acetic acid derivative. An intermediate half-life. The analgesic dosage is 200 to 400 mg 3 to 4 times daily. The recommended dose in OA and RA is 300 mg twice or 3 times a day up to 500 mg twice a day, initially followed by a maintenance of 600 mg per day. Ibuprofen. It is a propionic acid derivative whose S enantiomer inhibits COX non-selectively. It demonstrates enterohepatic circulation with extensive hepatic metabolism. Its S and R enantiomers are metabolized differently and undergo minimal chiral conversion, unlike other propionic acid derivatives. Indications and dosage. It is approved for OA and RA. It is also used for postoperative analgesia and ophthalmic indications. It is available orally and as a sodium salt in topical ophthalmic formulation for inhibition of intraoperative miosis. Intravenous flurbiprofen, lozenge, and oral spray are available in Europe. Adverse effects. Its adverse effect profile is similar to that of other NSAIDs in most ways. Also rarely associated with cogwheel rigidity, ataxia, tremor, and myoclonus. Ibuprofen. It is a simple phenylpropionic acid derivative. A non-selective COX inhibitor. It is available in oral, topical, and intravenous forms. Indications and dosage. Oral ibuprofen is indicated for OA, RA, and JRA. It is available over the counter as 200 mg tablets. In doses of 2,400 mg per day, ibuprofen is equivalent to 4 g of aspirin in anti-inflammatory effect. At less than or equal to 1,600 mg per day, it is analgesic but not anti-inflammatory. Oral and 4-ibuprofen are effective in closing patent ductus arteriosus in preterm infants, with much the same efficacy and safety as indomethacin, but it may cause higher bilirubin levels. Preemptive 400 to 600 mg ibuprofen can effectively manage postoperative pain, decrease TNF-alpha and IL-1 beta, and reduce opioid consumption. A topical cream preparation is absorbed into fascia and muscle. It can cause compensated hypogonadism with decreased testosterone production and secondary increased LH/FSH, resulting in normal testosterone levels but a stressed system, hypothetically resulting in long-term effects. Not proven. Adverse effects. In comparison to indomethacin, ibuprofen decreases urine output less and also causes less fluid retention. The drug is relatively contraindicated in individuals with nasal polyps, angioedema, and bronchospastic reactivity to aspirin. Aseptic meningitis, particularly in patients with SLE. Rare hematologic effects include agranulocytosis and aplastic anemia. The concomitant administration of ibuprofen and aspirin antagonizes the irreversible platelet inhibition induced by aspirin, limiting the cardioprotective effect of aspirin. Common adverse effects are listed above. Indomethacin. It is an indole derivative. It is a potent non-selective COX inhibitor. May also inhibit phospholipase A and C, reduce neutrophil migration, and decrease T-cell and B-cell proliferation. Indomethacin differs somewhat from other NSAIDs in its indications and toxicities. Indications and dosage. The drug is recommended for OA, RA, AS, bursitis/tendinitis, and acute gouty arthritis. Dosage of 50 to 70 mg TID may be increased by 25 mg or 50 mg up to 200 mg per day. It accelerates closure of patent ductus arteriosus. It has been tried in reactive arthritis, Sweet syndrome, JRA, pleurisy, nephrotic syndrome, tocolysis, diabetes insipidus, urticarial vasculitis, post-episiotomy pain, Prophylaxis of heterotopic ossification in arthroplasty and COVID-19. An ophthalmic preparation is efficacious for conjunctival inflammation and to reduce pain after traumatic corneal abrasion. Gingival inflammation is reduced after administration of indomethacin oral rinse. Epidural injections produce a degree of pain relief similar to that achieved with methylprednisone in post-laminectomy syndrome. It is also available in a rectal formulation. New low-dose indomethacin, 20 and 40 mg capsules containing submicroscopic particles provides analgesic efficacy in acute postoperative pain. Adverse effects. At usual dosages, indomethacin has the common adverse effects listed above. The GI effects may include obstruction, ulcerative colitis, and regional ileitis. Headache is experienced by 11.7% of patients. It can aggravate depression, epilepsy, and Parkinsonism. It is rarely associated with corneal deposits and retinal disturbances decrease it. Ketoprofen. It is a propionic acid derivative. Inhibits both COX non-selectively and lipoxygenase. Concurrent administration of probenecid elevates ketoprofen levels and prolongs its plasma half-life. The effectiveness of ketoprofen at dosages of 100 to 300 mg/d is equivalent to that of other NSAIDs. Its major adverse effects are on the GI tract and the central nervous system. See common adverse effects above. Nabumedone. It is the only non-acid NSAID in current use and resembles naproxen in structure. It is a non-selective COX inhibitor. It is given as a ketone prodrug. 35% of a 1,000 mg dose is converted to its active naphthalacetic acid metabolite. Renal impairment results in a doubling of its half-life and a 30% increase in the area under the curve. Indications and dosage. The recommended starting dose for OA and RA, e.g., 1,500 to 2,000 mg/d, often needs to be exceeded, and this is a very expensive NSAID. Adverse effects. Adverse effects are very similar to those of other NSAIDs. While diarrhea, dyspepsia, and abdominal pain are experienced by 12 to 14% of patients, the incidence of GI ulceration is lower than that seen with most other NSAIDs. Naproxen. A naphthylpropionic acid derivative. It is a non-selective COX inhibitor. It is the only NSAID marketed as a single enantiomer. Naproxen's free fraction is significantly higher in women than in men, but half-life is similar in both sexes. Indications and dosage. Naproxen is effective for OA, RA, AS, pain, and bursitis/tendinitis. It is also used to treat JIA, acute gout, and migraine. It is available as a slow-release formulation oral suspension over-the-counter as 220 mg tablets with sumatriptan for migraine as a topical preparation and as an ophthalmic solution. Adverse effects. Common adverse effects include pressure sensations, nausea, dizziness, and somnolence. The incidence of upper GI bleeding in over-the-counter use is low but still double that of over-the-counter ibuprofen, perhaps due to a dose effect. Naproxen has a more favorable cardiovascular risk profile than ibuprofen. Rare cases of allergic pneumonitis, leukocytoclastic vasculitis, and pseudoporphyria as well as the common NSAID-associated adverse effects have been noted. It is contraindicated in patients with hepatic impairment. Oxaprozin. It's another propionic acid derivative NSAID. Is a non-selective COX inhibitor. It has a long half-life of 50 to 60 hours and is given once daily. Indications and dosage. It is used to treat OA, RA, and JRA. Adverse effects. Its adverse effect profile is like that of other propionic acid derivatives. Piroxicam, an enol carboxamide derivative, is a non-selective COX inhibitor. At high concentration also inhibits polymorphonuclear leukocyte migration, decreases oxygen radical production, and inhibits lymphocyte function. Piroxicam undergoes extensive enterohepatic circulation as indicated by its long half-life of 57 hours, so once daily dosing is appropriate. Steady-state levels are reached within 7 to 12 days. Indications and dosage. The recommended dosage for OA and RA is 20 mg qd. Adverse effects. At dosages higher than 20 mg per day, piroxicam increases the incidence of peptic ulcer and bleeding. See common adverse effects listed above. Sulindac. It is a sulfoxide non-selective prodrug whose active metabolite is a non-selective COX inhibitor. It is reversibly metabolized to the active sulfide metabolite and has enterohepatic cycling. This prolongs the duration of action to 12 to 16 hours. Its metabolite has less effect on renal prostaglandins and thus has been used when renal function is somewhat compromised. Indications and dosage. It is used to treat OARA as bursitis/tendinitis and acute gouty arthritis. It may suppress familial intestinal polyposis. Adverse effects. It shares the usual NSAID adverse effect profile. It is sometimes used in the face of moderate renal compromise. Rare severe adverse reactions include thrombocytopenia, agranulocytosis, and nephrotic syndrome. It is sometimes associated with cholestatic liver damage, pancreatitis, and aseptic meningitis in patients with SLE and mixed connective tissue disease. Co-administration of dimethyl sulfoxide, DMSO, may cause peripheral neuropathy. Tolmetin. It is a pyrrole alkanoic acid derivative, a non-selective COX inhibitor. It is rarely used today. It has a short half-life of 1 to 2 hours and reaches peak plasma concentrations within 0.5 to 1 hour. Indications and dosage. It is indicated for OARA and JRA and is apparently not effective in gout. Adverse effects. Nausea occurs in 11% of patients and acute interstitial nephritis has been observed. Common adverse effects are listed above. Other NSAIDs, azapropazone, carprofen, meclofenamate, and tanoxicam are rarely used and are not reviewed here. Choice of NSAID. All NSAIDs, including aspirin, are about equally efficacious with a few exceptions. Tolmetin seems not to be effective for gout, and aspirin is less effective than other NSAIDs, e.g., indomethacin, for ankylosing spondylitis, AS. NSAIDs tend to be differentiated on the basis of toxicity and cost-effectiveness. For example, the GI and renal side effects of ketorolac limit its use. Indomethacin and tolmetin are the NSAIDs associated with the greatest toxicity, while salicylate, aspirin, and ibuprofen are least toxic. For patients with renal insufficiency, non-acetylated salicylates may be best. Diclofenac and sulindac are associated with more liver function test abnormalities than other NSAIDs. The relatively expensive selective COX-2 inhibitor celecoxib is probably safest for patients at high risk for GI bleeding, but may have a higher risk of cardiovascular toxicity. Celecoxib or a non-selective NSAID plus omeprazole or misoprostol may be appropriate in patients at highest risk for GI bleeding. The choice of an NSAID thus requires a balance of efficacy, cost-effectiveness, safety, and numerous personal factors, e.g., other drugs also being used, concurrent illness, compliance, medical insurance coverage, so that there is no best NSAID for all patients. There may, however, be one or two best NSAIDs for a specific person.